So the chemotherapy regimens and the two backbones that are most commonly used are FOLFIRI or FOLFOX. And then some would use CAPOX, which essentially is capecitabine, the oral equivalent of a fluoropyrimidine, with oxaliplatin. But if you want to look at these regimens, with FOLFIRI and FOLFOX, the risk of grade 3 and 4 diarrhea is about the same. The risk of grade 1 and 2 diarrhea is higher with FOLFIRI than with FOLFOX. With FOLFIRI, you're more likely to see alopecia. About 80% of the patients will lose their hair. You also have the risk of neutropenia. With FOLFOX, you have the risk of neurotoxicity, which after a cumulative dose of 750 to 850 milligrams per square meter becomes quite significant. And the problem for the majority of the patients, although the neurotoxicity may improve, it never really goes away and it stays at a baseline of grade 1. For about 1 to 2% of the patients, it's grade 3, which is pretty significant, meaning it's incapacitating. And it usually happens after the 4th or 5th month of treatment. So this is where you want to be mostly cognizant of it. The other risk to oxaliplatin is significant thrombocytopenia in 5% of the patients, about grade 3 or 4, about 5% of the patients, which could prohibit those patients to receive further therapy. This is mostly because of hypersplenism. It induces sinusoidal obstruction and essentially swelling of the spleen, which doesn't resolve on its own. In few patients, you have to actually remove the spleen if indicated. So they have their different toxicities. And some are manageable, others can tend to be more chronic, like neurotoxicity.
To what extent do you consider treatment effects on patients